So this is a trial in progress poster, and as such we haven't got data yet. But it's a really interesting trial. We're just starting because you're aware that Keynote 522 really changed the way we're treating stage 2 and stage 3 early stage triple negative breast cancer. We established in that trial that the addition of pembrolizumab to preoperative chemotherapy substantially improves the outcome, reduces the risk of death by 34%, and has therefore become the standard of care in patients with stage 2 or stage 3 triple negative breast cancer. Despite that big step forward, unfortunately we still can't cure all patients. We still have too many recurrences, and our job is now to improve those outcomes. So TroFuse 032 trial, which I have the pleasure to present here as a concept, the trial is only just starting, is trying to take this to the next level. What we're doing differently to the Keynote 522 trial, we're bringing antibody drug conjugates, sacituzumab TMT. We have learned from the top 2 ADCs that they can substantially increase response, but also in metastatic disease, progression-free survival, and overall survival. Now, I'm most interested here in the enhancement of the response and the possible positive interaction with immune checkpoint inhibitors. As we learned, for example, from the BEGONIA data, different ADC, but similar principle, combining a checkpoint inhibitor with an ADC has very high response rate here in a first-line metastatic setting of around 80%. We want to utilize that substantially increased activity in an early triple negative breast cancer setting. So this trial will try to replace the anthracycline part. Patients will be randomized to either sac-TMT plus pembrolizumab or AC or EC plus pembrolizumab, and then after the 12 weeks they'll be switched to the rest of the standard protocol, paclitaxel, carboplatin, and pembrolizumab. And we hope to see that by adding early at an early stage and antibody drug conjugates, we can both improve the path-CR rates as an early readout of success, but most importantly reduce the risk of recurrences, as we already managed to do in Keynote 522. So the BEGONIA trial is a platform trial that investigates combination of chemotherapy or targeted chemotherapy with immune checkpoint inhibitor. Basically the idea was, when we had established chemotherapy and immune therapy as a standard of care in patients with first-line metastatic triple negative breast cancer and PD-L1 positive tumors, we thought, where do we go next? How can we improve those results? And so we brought in different chemotherapy, immune therapy combinations, bringing in, for example, AKT inhibitors, but also, in my opinion, more interestingly, we replaced chemotherapy by antibody drug conjugates. There is a rational hypothesis that ADCs, because they're a massive microenvironment destructor, they break down the cancer cells more, they lead to an influx of CD8 positive cells, and we know to an upregulation of checkpoints, that hope that ADCs can possibly enable tumors to become more immune sensitive and essentially warmer. So the BEGONIA trial, the data presented here at ESMO 2025 are focusing on arm 7 and arm 8. Arm 7 is for patients agnostic of PD-L1, that included PD-L1 high and PD-L1 low tumors, but actually 87% of patients were what we classify PD-L1 negative. And interestingly enough, we saw a response rate of 79.9% with a PFS of 14 months and a duration of response of 70.6 months, which compares extremely favorably to single agent data we have seen in TROPION-Breast02, for example, in a largely similar cohort. Arm 8 is a little bit smaller and doesn't have enough follow-up at the moment, but that is a group of patients with PD-L1 positive tumors. And again, we saw very impressive response rates, 82%. The PFS and duration of response is immature at this point in time. But we're using those data in two ways. We're moving those data forward into a phase 3 trial called TROPION-Breast05, which is ongoing and recruiting. And this investigates Dato-DXd plus immune checkpoint inhibitor durvalumab in patients with PD-L1 positive tumors. But we also do an academic study in PD-L1 negative disease, where we compare Dato-DXd alone with Dato-DXd and immune checkpoint inhibitor to see whether we can resensitize those tumors for immune therapy. At this point in time, ADCs are moving from a second, third line setting into a first line setting. And we see this in patients with PD-L1 positive tumors in combination with immune therapy. And we see this in patients with PD-L1 negative tumors at the moment as single agent therapy. And I think they're there to stay. We can obviously speculate, as these ADCs are likely to move into early disease setting, whether and how we can reutilize them in a metastatic setting, but that is for future generations to work out. What I'm still interested to see, and one of the last remaining open questions is, can we utilize an ADC to widen the indication for immune therapy in metastatic triple-negative breast cancer? At the moment, the value of immune therapy, the utility is limited to patients with PD-L1 positive tumors. But the data of BEGONIA, difficult to interpret because we see a substantially higher response rate, progression-free survival, and duration of response in a group of patients who are essentially PD-L1 negative, 87% of patients. And that's a signal that is so powerful that it is difficult to know whether this is just the ADC. If you compare this now with the data of TROPION-Breast02, those data in BEGONIA look even better than that. So it raises the question, does the immune checkpoint inhibitor contribute to this in making those tumors more sensitive and ultimately improving response and long-term outcomes? And that's what we're evaluating at the moment in a randomized trial, Diamond academic trial, Dato-DXd versus Dato-DXd plus durvalumab. There's also a phase 3 trial ongoing, TROFUSE-11, which has 3 arms, sac-TMT alone, or chemotherapy, or sac-TMT plus pembrolizumab as an immune checkpoint inhibitor, same cohort, patients with PD-L1 negative tumors. And they will ultimately answer, I hope, the hypothesis whether we can render tumors immune sensitive by giving an antibody drug conjugate.